Kotalawadi Defense University, and she's also a consultant transfusion physician at the Department of Transfusion Medicine at the University Hospital of KDU. So I think it's quite rare that we are getting a specialist in this area to talk about this subject. And without further ado, I warmly welcome Dr. Trilisha for joining with us. And over to you, Dr. Trilisha. I hope you can hear me and start the
Thank you very much, Sri Lanka. Thank you very much, Sri Lanka Medical Association, for giving us the opportunity as the transfusion medicine fraternity. And this is a very important topic, as you mentioned. Having the knowledge would save the patient's life. And the transfusions, of course, happening throughout the world, and it's a common mode of treatment, and its reactions also very unique actually. So it's not moving. So the reactions also unique to that therapy because it's an allogenic product as well as it's a totally biological. So my presentations objectives will be the introduction to the basic transfusion reaction, management of the transfusion reactions, very basic management, and the prevention of certain reactions, it is very important, and how to report to the National Hemovigilance System. Transfusion adverse events can occur less than the 24 hours of the transfusion, where we call acute transfusion reactions. And it can occur delayed also, that means after 24 hours of the event of the transfusion. Here, I am just going to share the knowledge of acute transfusion reactions, and the delayed transfusion reactions can be divided into certain categories depending on their reason or cause. Immunological problems, that means the antigen antibody mediated reactions. We can get examples as acute hemolytic transfusion reactions, typically ABO incompatible transfusion reaction, febrile non-hemolytic, allergic anaphylactic, and transfusion related acute lung injury. Infectious causes also can cause acute transfusion reactions. Examples are transfusion transmitted bacterial infections. Acute transfusion reactions can be due to other causes like volume overloading, where we call transfusion-associated circulatory overload, or transfusion-associated dyspnea, also acute transfusion reaction. Same way, if we see the delayed transfusion reactions, that also can be immune-mediated due to the antigen-antibody interactions, delayed hemolytic transfusions, and alloimmunization also can cause transfusion-related problems. Infections are always, we know, transfusion transmitted infection is also a problem, and iron overloading kind of complications also can be considered as delayed transfusion problems. Here just I want to share with you how complicated and unspecific your patient present with transfusion related problems. I have just chosen several kind of symptoms, signs presenting with. Fever would be one of the commonest, but it can be seen in febrile non-hemolytic, acute hemolytic, Charlie kind of, and the bacterial contamination or septic transfusion reactions. If we take hypotension, which is a serious life-threatening situation where acute hemolytic transfusion reaction, severe allergic type, anaphylactic, bacterial contamination, transfusion-related acute lung injury, or circulatory overload also can present with hypotension. And the stridor B is angioedema, and the urticarial skin rashes would be. The minor presentations would be minor allergic presentations, and anaphylaxis can present with the severe stridor, wheezing, angioedema, and the urticaria. Hypertension also a unique presentation where circulatory overload can cause hypertension. Here, this cage presents dyspnea and hypoxia. This is a unique situation where patient present only with the respiratory signs and symptoms, where also we have to consider Charlie, transfusion-related acute circulatory overload, and severe allergic transfusion reactions. Here you can have some idea that all the presentations are very non-specific, and normally by experience we don't see books presentations also when we are dealing with the patients. If I just share this slide, this is from one of the publications which has happened in other countries, developed countries, how frequent this is. Transfusion reactions. So they have compared with the normal society happening the problems to the patients, death from a medical error that can happen in any situation, but how common our transfusion reactions are, it is commoner than that situation. And then they have taken the motor traffic accidents leading to a death. So certain transfusion reactions are actually commoner than that. Then they have compared with the death due to lightning situation. Actually, it's a rare occasion. So how it happens related to the transfusion reactions. Airplane death is a extremely uncommon situation. So in those countries, HIV, HCV kind of infections are very rare. Because their technologies are really advanced and their testing technologies advanced to that level. They don't take it as a problem actually because of the transfusion. So we can't compare everything to our setup because our settings are a little change in that aspect. If I go to one by one, acute hemolytic transfusion reactions, I mentioned it can be immune and it can be non-immune also. Acute immune-related transfusion reactions, acute hemolytic transfusion reaction. This is very important topic out of all the transfusion reactions. Incompatible red cell transfusion of incompatible antigens. That means after 4 months of the age, everybody is having anti-A, anti-B antibodies in the plasma. If we give A antigen, that means A red cell product to that person, there can be antigen-antibody interactions happen intravascularly. So that can cause incompatible transfusion reactions due to the incompatible red cell transfusion. On the other hand, the reverse way also that can happen. If we give O plasma, which contains anti-A and anti-B antibodies to A patient or B patient. So where incompatible plasma can lead to acute hemolytic transfusion reaction. So this slide shows the pathogenesis or pathophysiology, what's happening in the acute hemolytic transfusion reaction. So it is happening in the intravascular system. And when the incompatible red cell comes, in the patient, we have these anti-A, anti-B antibodies. We have to remember these antibodies are IgM in nature. They are really big molecules and they are naturally occurring antibodies and they are really potent. They are 37 reactive. And these antigen antibody complexes can activate this unique defense system of the immune system of our body, complement system. So when the complement pathway is activated by attaching this antigen antibody on this red cell, so it can go up to the completion of the pathway. At the end of the it produces the membrane attack complex where red cell can be burst and all the cellular materials can come out from the cell. Meantime, it may produce as a byproduct C3A, C5A like. These are anaphylaxis toxins. These can cause serious side effects on the in the body. So one thing is that they activate these mast cells. So then the mast cell activation can cause vasodilatation, hypotension, and shock. So the hypoperfusion directly affects certain organs. Main organ, one of the main organs are kidney, so which can lead to acute kidney failure. So meantime, if this immune-mediated red cell lysis occurs in the intravascular system, the red cell destruction happens, free hemoglobin comes out. This free hemoglobin is not normal to the body. It has to go out from the body. 2 organs are contributing to excretion. So it comes through the kidney where it's partly contributed to acute kidney failure. And these complexes will be taken up by the liver also, where liver also getting affected. So, and we can see this type of investigations, positive investigations, and hemoglobin will be anyway reduced. Our aim was to increase the hemoglobin by giving this red cell, be in an incompatibility where hematocrit and hemoglobin will be low. And on the other hand, this immune-mediated hemolysis, it increase the tumor necrosis factor, and it causes cytokine storm, where we can see this fever, leukocyte activation, and thrombosis. Ultimately, this tissue factor generation and activation of the coagulation system can cause disseminated intravascular coagulopathy. So in incompatible transfusion, all these scenarios can occur, ultimately leading to a death or severe morbidity can also possible unless we manage the patient timely. So the presentation would be vary depending on the patient's immune system, how much of red cells we have given to the patient, and how is the rate and the rapidity of the transfusion. Book says it present very early. Typically, in majority of patients, it present very early, and they say it's enough that 10 ml of incompatible transfusion to activate the complement system. So we can see fever, chills, pain at the site would be a very early indication. Infusion is starting, and we have to take these are very alarming signs. And this problem called non-specific, but it is a multi-systemic symptom. Patient may tell you, I'm feeling of impending of doom. That means I can't explain what it is happening, but something very abnormal. So this is, of course, very non-specific, but if somebody says that something is going on during the transfusion or just after the transfusion, take it as a serious complaint. And unless proven otherwise, you have to exclude ABO incompatible transfusion at that moment. Loin pain could be due to the inflammation of the kidneys, and that encapsulated area is expanding, which causes loin pain, back pain, and tachycardia and hypotension also can occur due to those complement activation. And as I mentioned you, the complications of the acute hemolytic transfusion can be this much. Shock, hypotension, and bronchospasms. We know now pathophysiology. Renal ischemia can cause acute renal failure, and the cytokine network activation can cause fever, hypotension, and coagulation activation can cause ultimately disseminated intravascular hemolysis. So having the baseline knowledge on the pathology, if we work out the laboratory findings, so we can see or we can find hemoglobinemia, hemoglobinuria, because this free hemoglobin is passing through the urine. Decreased hematocrit and decreased hemoglobin is obvious, and this haptoglobulin will be reduced. It's a very good marker of this intravascular hemolysis. LDH would be increased, and we can show the presence of plasma hemoglobin, and bilirubin increment would be little later. After 6 to 12 hours later, you can see hemoglobin increment also. So if I just mention you, acute hemolytic transfusion reaction can be immune, it can be non-immune also. So the mechanical causes like artificial heart valves, where now this is not a common artificial heart valve, so we don't see now. If there's a heart valve kind of thing, if the flow, turbulence of the flow can cause damage to the red cells. Extracorporeal circulation also, it's same as that. And this is very important practical point, transfusion through small bore catheter under high pressure. So sometimes when we connect to a cannula, if the cannula, the bore is not enough to pass the red cells freely, where the lysis can occur inside. And it will be additional effect if you press or compress the pack, which is not recommended at all. So you can't do any pressing or anything, because these are stored red cells. So they are really under pressure in the this system, because their nature is circulating inside the very good vascular system. Now it is in a plastic bag, though we provide certain support, but it is totally, we have to accept they are at a liable situation. And if we add certain other solutions like hypotonic or hypertonic like dextrose or any drugs to the blood pack, it will hemolyze then and there. Heating of this red cell will not be accepted. We know it is not compatible. It can't tolerate it. So if we put it as a condition of warm into the water bath or some oven or kind of thing, we don't recommend anything. There are standard warmers if you really need to warm. But it is no need for 1 or 2 transfusions. If it is a massive transfusion only, normally we recommend, or pediatric massive transfusion. So the freezing also can cause the mechanical hemolysis. And in these situations, patient may present with hemoglobinuria, but the shock and hypotension will not present as such. So the management. So this is very important. Everybody in and out, we have to know when we qualify MBBS or nursing officers kind of how to manage a acute hemolytic transfusion reaction. Any time can happen. So it's a medical emergency. Stopping the transfusion should be done. It is the first most thing. And you have to manage patients' airway, breathing, circulation, and you can see what is happening, monitoring, closely monitoring, because at the first moment, you may not detect any abnormality, but if it is obvious acute, this incompatible transfusion, definitely patient may present. So you have to identify the blood group discrepancy after stopping while managing and monitoring. So you can check whether patient's blood group is the PAC group. And you have to start normal saline infusion, and patient may collapse next moment going into hypotension. So you have to insert another cannula, which may not be possible if the patient deteriorates. So the saline infusion may facilitate to take out all the incompatible red cells, antibody-coated red cells, and all the immune complexes from the body, which should facilitate the urine output. You have to monitor the output, and you can give fusimide doses as well. So if the patient develop hypotension, you have to support with inotrope. And it's good habit to inform the blood bank, because all our blood bank medical officers are trained and competency assessed people. They know which product, what has happened, what to do. Especially the junior medical officers can get the assistance from the blood bank. So check any other patient receiving the transfusion, because sometimes you may have received 2 units. Normally, we don't send 2 units at the same time in the same one box to the ward. But if you have another patient, please check whether other patient also may receive in a incompatible transfusion. And always have the help, call the help, and early attendance. We can minimize the morbidity and mortality. So we must do this, because if we allow the patient to die due to incompatible transfusion, we have to expect the legal implications as well, because this is not an accepted thing. Somebody has done something error, nothing wrong with the patient. And always have the baseline investigations, and repeating investigations at the regular intervals are recommended, because baseline would be normal at the first initial moment. As I mentioned, it is a never event, these events are not accepted actually. So it is 100% preventable. So which of course is due to the bad practices or not adhering to the protocols. The clerical errors, if we can just improve our practices in documentation, patient identification, at the prescription, at the requesting, at the sampling, and when we are doing at the blood bank testing, as well as at the back when we are administering the product. So sample errors are leading to the incompatible transfusion, because you have taken a sample from some other patient where we can't identify, because blood is same in all the patients. So if you put a wrong label on the tube, nobody can identify. It may lead to incompatible transfusion. At the time of the reaction only, we may investigate and find out. So positive patient identification at all steps is mandatory. And we have to do the correct testing protocol, that is to blood bank. And the administration errors, we have to practice and adhere to good bedside transfusion practices. So identification is very important at all steps. That may save the life, and safe transfusion will be ensured. So the second transfusion reaction would be this febrile non-hemolytic reaction, which is very common actually, not serious as hemolytic transfusion reaction, where patient may present with temperature of more than 1 degree or 1 degree Celsius. It will be during the transfusion, not as early as the acute hemolytic transfusion or just at the end of the transfusion, or at the midpoint, or after the transfusion. So it may join with, or just chills and rigors also may present with fever, and no serious signs normally present. This is common in the frequently or regular transfusion recipient like thalassemia or this myelodysplastic syndromes, where they regularly exposed to the donor antigens, where they form antibodies. So good to know the pathophysiology or pathogenesis, how is happening. So the main feature here is fever. How fever occurs? This is not a disease. No, fever is a kind of a alarming sign which gives from the body due to this activation of interleukin 1, 6 and tumor necrosis factors are the main contributors. So how these factors generated is from the antibodies from the white blood cells, antibodies to the platelets, and bioactive substances. During storage, many things happen. You may not be knowing. I also may not be knowing 100%. Actually, many things happen to the pack inside. So, when we are giving transfusions, we have to be keep all these in mind. In any case, these can be expected. So the management of the FNHTR antipyretics, that means our paracetamol would be the best drug there. We don't recommend NSAIDs. And the pre-medication, that means you had the patient now FNHTR and you think now next transfusion would be getting this one. We have to make the patient comfort, but nobody in the guidelines recommend pre-medication because that masks all the important signs and symptoms also. So unless prescribed by a specialist, we don't recommend pre-medication. So let the patient to have or present it. You have to be there for the management. It's only the symptomatic management. Here for especially for this type of minor FNHTRs, you can make it comfortable, or we can make the patient comfortable by making the slower transfusion. So all the transfusion regular recipients, I advise, of course, to keep the slower rate so that may comfortable for the patient. Actually, we don't need to give any other drug or modification. We don't need to stop transfusion nodes. The reduction, that means we remove the buffy coat where some amount of leukocytes will be produced. Internationally, they remove by filtration. So the significant number of WBC will be removed, where in our country, our routine transfusions to regular transfusion recipient would be this leukoreduced red cell concentrates. The third one would be the allergic transfusion reaction. Here, of course, it is a common scenario. Any foreign material can be act as an allergen to the recipient. So it is as normal as other allergic reactions. So it is IgE mediated. Here, mainly the blood pack may contain the plasma proteins. So this may be the positive factor. And don't think these are recurrent. That means once it happened, so we can't say that all the other donors' plasma also make an allergic reaction to this patient. So commonest type out of allergic reactions would be mild, where the cutaneous manifestations and the GI manifestations and mild bronchospasms can occur. Severe allergic reaction that you have to know, anaphylaxis or very severe near anaphylactic reactions could be due to patients with IgA deficiency, where they can have anti-IgA antibodies in the plasma. So where all our donors, normally they have IgA as a normal antibody. So that may react and it can cause severe allergic reactions. In our part of the world, actually, people say it's not only the IgA deficiency, more important anaphylactic transfusion reaction due to the haptoglobulin deficiency. These can be assessed. But we can do the investigations. Just keep in mind, if you have a patient with severe allergic reaction, it's very important to investigate and give a good future transfusion management plan. So the mild to moderate allergic reactions can be managed by the antihistamine and hydrocortisone. If I just make a note, now don't think all the transfusion reactions are allergy. So all the patients are just the indication of antihistamine and hydrocortisone are there for all the transfusion recipients, because it is not the thing, because different transfusion reactions due to different pathologies. So only place for the antihistamine and hydrocortisone in the transfusion reaction management is only at the minor allergic reaction. Severe allergic reaction, it is no use, or later only we have to introduce antihistamine and hydrocortisone. IM adrenaline is the drug of choice, and we have to introduce the saline or some expanders where hypotension can be characteristic, and always make a chance to investigate serum tryptase level. We can do it in our country, and IgA level, and even anti-IgA antibodies can be tested here. And always have a good practice to documentation, explain to the patient, do the counseling, and give a transfusion plan from the transfusion specialist. The next one would be really interesting, as well as it may be underdiagnosed also in our practice, transfusion-associated circulatory overload. By definition, it says acute or worsening respiratory compromise and acute or worsening pulmonary edema during or up to 24 hours of the transfusion, with additional features including cardiovascular changes not explained by the patient's underlying condition. Evidence of fluid overload or relevant biomarkers can be visible. So ISBT says out of following these signs and symptoms, if it is present within the 6 hours of the transfusion, we can make the diagnosis of TACO. Acute respiratory distress, tachycardia, increased blood pressure, acute or worsening pulmonary edema, and evidence of the positive fluid balance. So we have to identify these risk groups because all the patients are not normal. Their cardiac function and renal function are different. So when it comes to the extremes of the age, they are at risk of volume contribution. And we have to have some idea how much of volume contains in our red cell pack, FFP therapeutic dose, and the platelet therapeutic dose. And if the patient is having severe anemia, cardiac renal involvement, or any other kind of pregnancies, then the too rapid transfusion. Actually, people say hyper enthusiastic. That means many red cell units are given very rapidly to correct the hemoglobin. Ultimately, patient develop the failure. So the presentations, we know it is the heart failure or pulmonary edema. It can cause morbidity as well as mortality unless we manage promptly. So the respiratory distress, increased BNP, CVP, and the left heart failure, positive fluid balance, or the radiological evidence of the pulmonary edema would be the presentations. So the prevention is very important. Ideally, in other countries, they have to assess the TACO risk assessment before starting the transfusion. So then we can initiate these measures. We can give the volumes, not for all the patients a unit or the dose exactly. We can calculate it to the body weight. Pediatric, anyway, we have to do. And even adults, if the body weight is 40 or less than 40, emaciated, well-developed adults, we don't need to give 1 unit. And we can introduce the diuretics also, where the current recommendation is actually after the first half an hour or before the half an hour of the transfusion only they recommend. But we know that our practice is at the midway. I don't know what is the benefit giving diuretics. And all the patients should not receive diuretics also because sometimes it causes volume depletion as well. So the transfusion slowly under close monitoring would be really good practice, and divided doses. If you have platelet dose of 8 units, 6 units, you can ask blood bank or discuss with them 3 units, 3 units, or FFP 2 units, 2 units, like a divided doses would be beneficial for risk patients. This is very important transfusion reaction, acute transfusion related acute lung injury. We know it is TRALI. This is non-cardiac pulmonary edema. This majority of cases are due to the donors having the antibodies. These antibodies are human leukocyte antibodies or human neutrophil antibodies. So donors who had transfusions or multiple pregnancies, they have exposed to others antigens and have antibodies. So this is also not the clearly, if unless we made a good clinical diagnosis, we may miss. Here, I just compared the TRALI with the TACO, cardiac failure. Here you can see the alveolar shadows. This is very unique and characteristic. Here, the cardiac enlargement would be characteristic and the curly B signs would be characteristic. So a little bit about the pathogenesis. It's interesting to know why all the patients, they don't develop TRALI if we give these products. So if they have a first hit, that means there are patient contributory factors. If your patient is having septic or sepsis, septic shock, or any hematological or any other malignancies disseminated, or massive transfusion, or other organ failure, so patient is actually just at the prime stage. On top of that, if we give lot of plasma products, especially plasma containing products, platelets, FFP, critically ill patients, normally they receive. So the second hit would occur where the red cells, we introduce HLA, HNA antibodies, where the donors having antibodies, FFP, platelets, and these bioactive lipids. And there are so many active things happening in this stored blood, as I mentioned you earlier. So already this patient is at the very high risk. So where we just introduce these kind of materials where they just ultimately ended up with the alveolar injury. What will happen here is actually the primary site affecting this trial is the alveoli, where all these antigen neutrophil, leukocyte, neutrophils and leukocyte antibodies, they come and damage the alveolar membrane that can cause the fluid leak and then acute respiratory distress. So it is purely a clinical diagnosis. Laboratory support comes little later. Typical trial, if you see, it is if acute onset within 6 hours of the blood transfusion. Sorry, if your patient present with PaO2, FiO2 less than 300 mercury milliliters or bilateral infiltrative changes on the chest X-rays, no hydrostatic pulmonary edema. That means that is for the TACO. Or no other risk factors for acute lung injury, you can just think of this is a very possible case of, very likely case of TRALI, and you have to get the advice from the blood bank, and you have to arrange the investigations. Possible TRALI and delayed TRALI also people have identified. Especially patient may present with above symptoms and signs after the 6 hours up to 72 hours of the blood transfusion. This would be the typical X-ray finding. This X-ray is pre-transfusion. This is post-transfusion. You can see how many exaggeration of the lung shadows. So the exclusion of other differential diagnoses like cardiac pulmonary edema and ARDS very important. And new findings should be established. And laboratory diagnosis, we can do HLA, HNA antibodies of the blood donors, as well as the antigen typing can be done in our country. We have the facilities to make the definitive diagnosis. The management of TRALI would be mainly supportive. Intubation may be necessary if severe hypoxia, and fluids may be necessary. Steroids we can try, but no as evidence. And usually it is spontaneous recovery. We have to support the patient for 48 to 72 hours. The prevention is very important. We have to identify risk patients. So at the clinical setup, transfusion of plasma product to critically ill patients should be decided with careful analysis of the benefit patient gets. And from the blood bank side, we can trace up the donors and screen for the leukocyte antibodies. We have to avoid bleeding these plasma donors, plasma if they have antibodies. This is, of course, is something you have to consider hypotensive transfusion reaction, where the unique feature is hypotension, no other symptoms or sign. Normally, we do see with the platelet and red cell transfusion, where this bradykinin generation, because of this plasma contact with the artificial surface of tubing, which causes vasodilatation and hypotension. There's a unique situation. So this will, if you stop the transfusion immediately and you give some fluid support, there would be rapid resolution. Especially if your patient is on ACE inhibitory drugs, you have to just, if the patient develop hypotension, think about this type of transfusion reactions. Transfusion-associated bacterial sepsis. This is due to contamination of the blood product. So the blood product is anyway from the donor. So we have to be very much careful when we are bleeding the donor. Donor selection has to be up to the standard techniques, and more common in the room temperature stored blood products in the platelets. This is a problem worldwide. So diagnosis normally after exclusion of other sources and proof of the cultures to identify the organism in the patient as well as in the implicated pack should be done. And the common skin flora, transient bacteremia of the donor, or the contamination during the handling or the storage are the risk factors. We have to prevent by adhering to the protocols, and we have to avoid keeping blood components out of the temperature. In the clinical setup, when the blood issued from the blood bank, it should immediately go and connect to the patient. So all the patient preparation, cannula insertion, temperature check-in, everything, and people should be around, medical officer and a nursing officer for the management should be done before you send the porter to bring blood unit. So if you do that one, you don't need to keep any pack outside. If you expose to the near 37-degree temperature, definitely there will be high colony counts if 1 or 2 bacteria is already gone inside the pack. So always start the transfusion as early as possible. And you have to adhere to the maximum transfusion durations. Red cells would be maximum up to 4 hours only we can give. If there are remaining red cells after 4 hours, you have to remove the pack. And other components, normal recommendation is half an hour to 1 hour, but always think whether that dose can be accommodated to the patient's system. So the patient's tolerance should be assessed and decide on the volume and the rate. So otherwise you can divide the dose and give it. I just made this charts to show you how the contaminated blood product looks like. So this is a the platelet product. So where you can see abnormal, this agglutinations present. In the red cell, it can be color change. There can be bubbles. There can be clots as well. And if you give this kind of pack, patient may present with very high fever and chills, trigos, GI symptoms, hypotension, hemolysis can present, and shock and ultimately multi-organ failure. So the general investigation should be done, full blood count, blood picture, and the organ function. Coagulation profile is very necessary. And you have to take cultures from 3 different sites from the patient and the culture from the pack as well. So the supportive care is very important, and you can start broad spectrum antibiotic at the start if you suspect this kind of reaction, and change over to the sensitive antibiotic. And all the components from this particular donor should be recalled by the blood bank. And there are some other acute transfusion reactions with unknown pathology. Transfusion-associated dyspnea, where the dyspnea is slowly due to some kind of unknown reason, and trali and taco is excluded. And pain. Patient present with severe pain over the trunk and the proximities immediately after transfusion, which is also due to unknown cause. So the acute transfusion reaction are over. So delayed transfusion reaction, this kind of list can be seen or identified after 24 hours. Person may present after the 24 hours the transfusion, this kind of presentations. If we just see this delayed hemolytic transfusion reaction, where after 24 hours, patient's donor red cells are breaking down inside the person's circulation, delayed hemolysis. This is due to the secondary immune response following exposure to the red cell antigens. The destruction of RBC through extravascular hemolysis, in contrast to the acute hemolysis, where intravascularly through complement system it occurs. Here the main organs are the liver and the spleen. And the primary sensitization could be a transfusion or pregnancy or transplantation. So the junior medical officers, house officers, when you request blood, you have to mention whether patient having any transfusion or any this kind of antibodies. If you have come across that, you have to make the history should be clearly identified. And here we know now when the primary exposure happened, after some time it may at the dormant state at the plasma cell level. So when the re-exposure happened, so there may be adequate amount of antibodies where that red cell would be hemolyzing when it comes to the higher doses. So it is less severe than the acute hemolytic reaction, obviously due to there's no complement activation. And clinical presentation, normally they come back to you after red cell transfusion, you discharge, and patient also go home. After again 5 to 10 days time, they admit with same signs of anemia, fever, malaise, fatigue, and you will demonstrate no hemoglobin increment. Earlier it may be increased, but now it is again back to the normal level. And the blood bank can demonstrate the positive direct antiglobulin test, where we can demonstrate the antibody coated these red cells in the patient's circulation. Other things are very rare. These complications may not see, but you have to identify and support the patient. Prevention is very important here. So we the blood bank people must do the pre-transfusion antibody screening in all patients. Now it is the recommended practice. And if any person identified antibody any occasion, so you have to explain to the patient and give an antibody card. National Reference Laboratory supports us identifying the antibody. And we have to cross-match the antigen negative transfusion for all future transfusions. This is anyway extremely rare, but it is highly fatal. Transfusion-associated graft versus host disease. This is extremely rare because everybody doesn't just get this type of reaction. Usually, this is caused by engraftment of immunocompetent lymphocyte in the immunocompromised patient. This is the usual pathogenesis, but sometimes it occurs transfusing cellular components among the first-degree relatives where they share HLA haplotypes. We have to identify risk groups. Actually, I didn't make the full list. You can go to this BCSH guideline and find out. We also follow BCSH guideline. So not all immunocompromised patients undergo this type of reactions if you give cellular products. Certain immunocompromised patients, HLA match products, intrauterine transfusions to fetuses, and after those intrauterine transfusions, newborns are at risk. Granulocyte transfusion recipients are always at risk, and family member transfusion. Normally, we don't recommend interfamily transfusions. Only extreme situations only we consider as they are as donors. So the presentation would be 1 to 2 weeks after transfusion, fever, diarrhea, and this kind of erythematous skin rashes, and the poor liver functions. And pancytopenia is very unique, which lead to infections. And there's no effective mode of treatment worldwide. There's nothing. And they try steroids and cyclosporins, but there's no evidence. And always the prevention is the recommended. We have to identify the risk categories. So we are as a clinical team and the blood bank team, we have to coordinate each other to help patients in this kind of situations. So we can do irradiation. That means we expose all these cellular packs or the blood components to X-rays, where it can inactivate the viable lymphocytes present in those components. So and we have to give a card after explaining. So they have to carry at each admission this card. Then only we know that he is a risk category group. This transfusion reaction is post-transfusion purpura, where severe thrombocytopenia can occur after 1 to 2 weeks of the transfusion of red cells or platelet concentration. In this condition, destruction of the platelets due to the preformed antiplatelet antibodies, like red cell antibodies, they have platelet antibodies also. So patient present with widespread purpura and bleeding manifestation. Sometimes this bleeding can be life-threatening kind of thing, where we may treat with steroids, IVIG, and the plasma exchange also, there's a place when we are managing. And once occurred, the next transfusion or future transfusion should be special component. So best practices have the team management with the transfusion team. Iron overloading also considered as a complication of transfusion, especially in the regular transfusion recipients. We know 1 unit of red cells contain 200 to 250 milligram of iron, and monitoring and the chelation should be done as the mandatory protocol. Then we detect the iron overloading and the organ damage. Transfusion transmitted infections, any pathogen present in the donor, there's a possibility to transmit if it is survival is there at that stored temperatures. So the bacteria, viruses, and other parasites are there. We know emerging and re-emergent infections can be identified. Once it is happened to the patient only, we know that it is a transfusion transmissible infection. So, and you have to remember all the infections or bugs cannot be traced up during the pre or the before transfusion donor screening. We do only the mandatory screening, mandatory testing at the blood bank according to the international guidelines. So the best thing is blood component should be used only for patients who will have a benefit and no other alternative, because all these transfusion reactions are highly possible. We have to anticipate. Immune modulation is a trendy topic with the transfusions. It's a new risk actually. So the what is happening here is increased infection rate in the post-op transfusion recipient. This is a proven, of course, in the critical ill patients. If we give lot of transfusions, that means we call liberal transfusions. So those patient groups are at risk of infections, that is demonstrated. And the certain tumors are recurring, and the end organ failure also seen, and cases are documenting. So actually in most of the countries now they are going for the this restricted transfusion regimes rather than the liberal transfusion regimes, because of these unknown complications can happen. So then the list of transfusion reactions, so the things I have explained, that's the immediate action in case of any transfusion reaction. I just give in a summary. Action 1, I just thought it is save. This is for the stop the transfusion immediately, assess the patient's airway, breathing and circulation, and verify the patient identity with the transfused unit, and confirm that the correct component was transfused, and examine the component for the bacterial contamination like color, clumps, aggregates present in the pack. Then the action 2, if you are a nursing officer, immediately you have to call a medical officer, because you are not competent to manage a transfusion reaction. If you are a medical officer, junior house officer, you have to attend immediately, assess the patient, and look for the signs of serious life-threatening situations, as we just mentioned here. And symptomatic management is the recommended. International recommendation is we don't need to think about whether this transfusion reaction is this diagnosis or kind of things. What is the patient present? That symptom should be managed. Continuous monitoring should be done. So the more severe presentations, you have to call the help or the transfusion team. They will help, not that cocktail treatment. Until the diagnosis is made, you can manage symptomatically. If there's evidence of life-threatening symptoms, always call help. That is always I am repeatedly telling, because then we can save the patient. Action 3, assess the patient and manage accordingly. Vitals should be monitored regularly. And always while managing the patient and the team, there may be helps or assistance coming, you have to report these transfusion reactions to the blood bank through the transfusion reaction notification form. And the samples of post-transfusion EDTA clotted, and the remaining blood bag. If the blood bag is empty, even the tube in empty bag should be returned back to the blood bank. Laboratory investigation should be done according to the clinical presentation and suspected reaction, and systemic evaluation should be done, and organ function should be evaluated in serious conditions. I just thought of sharing over my period of this over 20 hours of 20 years of in the field of transfusion medicine, and so many centers in the country. Incorrect practices so far still it is there, management of transfusions and the reactions. Just thought of learning from the errors, as exercise, learning from the errors. So the transfusion, some clinicians considered as a primary first line therapy without recognizing its complications, implications toward the patient, and the decision making without considering the risk versus benefit. So this is should be customized or individualized decision. If the patient getting the benefit only, we have to go for this kind of a therapy, because this is nothing curable. This is supportive. That doesn't mean that the needy patients who are leading to life-threatening situation like bleeding, we stop transfusion. But most of the transfusion recipients, we can evaluate and check for the alternatives as well. And patient identification is not correctly performed at the request in sampling and administration, which lead to ABO, incompatible transfusion. And pre-medication before start is to mask the symptoms. This is very unethical. I consider it as a very actually it's very bad, because you have to allow the patient to present and give the alarm signs, then somebody may come and manage. If you just suppress giving hydrocortisone, steroids or antihistamine, there's no chance him to have the presentation, but the reaction will be occurring inside the body. And delayed start of the transfusion and allowing the blood product to expose to the environment also, where I have seen, and which causes serious problems to the patients. And volume, rate, duration are not assessed per patient. So this is I recommend, or I just consider it should be customized to the patient, because their tolerance should be vary, and it is vary. And volume of the product should be included to the input in the risk patients. So for that one, you have to identify who are the risk categories. And then no proper monitoring of vital signs. The recommendation is before transfusion, within the 60 minutes of the transfusion, you have to check the vitals, and all the transfusion should be very slow until 15 minutes. Where we allow anything to happen, then we know what is happening to the patient. And we have to talk to the patient always before transfusion, and at the 15 minutes also, if any problem, then we can see patient may tell us. At the end of the 15 minutes, again, you have to check the vitals. Then only you can have the increase of the rate depending on the patient's tolerability. This rate should be given at the prescription by the consultant, where he is the responsible person or the senior most medical officer available in the unit at the time of the prescription. Junior officer must ask which product, which rate, at what time, everything should be clearly mentioned. And at the end of the completion also, you have to get the vital signs, or if any reaction, immediately stop and make it. So I have just to make it bold red color. The prescription of this antihistamine, piriton, and hydrocortisone to all transfusion reactions without managing patients symptomatically and without any reason. So this is, of course, is not good. And we do see the over the phone prescription by the medical officer. Until the medical officer comes, they ask nursing officer to do it. I request from all the nursing officers, don't just give any drug, because doctor has to see the patient. Then only doctor knows how to assess and what is the symptom, what kind of reaction, what kind of problem is happening. Then we have to manage accordingly, not the cocktail treatment of this antihistamine and hydrocortisone. This is really bad practice in our part of the world or our country. So no timely reporting of transfusion reactions to blood bank also we have seen, but we have to report because it is really good. So this is the last slide. So hemovigilance system is the national system. We have National Blood Transfusion Service. So hemovigilance system collect all the information about the adverse event and including the near miss events. So where you have not done the error to the patient, but if your error would have been made a major implication to the patient, those are near misses, that also we collect information. Don't be scared reporting to the hemovigilance system, because it is a service improvement. Then we can help you what is the correct practice. So all information received to this system, they handle with strict confidentiality. Your name, your signature, everything will be confidentially handled. And all the adverse event you have to report. Depending on the severity, you can't exclude. Irrespective of the severity, should be informed to the blood bank. And blood bank should investigate all events, and diagnosis and future management plan should be given to the ward as well as to the recipient. And all these reactions report to the blood bank. Weekly, we have to report to the national system. It is true online. Now we are reporting. And the hemovigilance system will evaluate those reactions, all island system, and we report, hemovigilance system will report what are the things. Actually, I just took this one from the short UK hemovigilance system. So where if we make the transfusion decision at the very beginning clearly, and if we have a plan, and if we assess the risk versus benefit, if we do see the alternatives and the patient categories, that would be a major take home message from my presentation. And hemovigilance also, I do consider if you report, learn, share, and ultimately improvement of the service would be a very good take home message. Thank you very much. I'm happy to take questions. You have 5 minutes.
Thank you. Thank you, Dr. Trilisha, for that very excellent and very comprehensive talk. I have a small question from my side. How common is it in Sri Lanka, as in the sense, how often do you see a transfusion reaction from your point of view?
Yes, the acute hemolytic transfusion reactions, that is the most important life-threatening. As I mentioned, it is some of the problems due to our team, blood bank team or the clinical team. So we had the 2023 national incompatible transfusions, where at the first quarter we had 9 incidents. Some were actually, I was also involved there, evaluation. Things are really, some incidents were really pathetic actually. So we have to pay attention. That means it's happening because those are due to human errors. So we all humans involved. Even other countries with all the sophisticated items like scanners and the label generators, still it is common. So in our country, it is the patient identification by communication, verbal. We have to talk to the patient. If the patient can't talk, we have to get the assistance from pediatric, from the bystander. If this is ICU setup or any comatose patient, extreme caution should be done to detect these type of problems. It is common. If FNHTR is anyway not life-threatening, it is anyway happening, but that is, of course, is a normal or expected thing. The most preventive mechanism should be to the ABO incompatible by adhering to the good bedside transfusion practices by the clinician and standard protocols at the blood bank.
Another question is that would we often see the temperature of the blood pack. Is there a issue with that when we transfuse
blood,
to a patient?
Yes. Different components store at different temperature to have its these are live cells and the live tissues. So red cells recommendation is at the 4 degrees. So when it comes to you to the ward also, it's almost at the 4. So as I mentioned, if you have the patient where the hypothermia would be a threat, that means actually cold hemagglutinin disease is the common medical condition where if they exposed to cold, the patient may exacerbate the hemolysis. Other than that, just 1 or 2 unit transfusion, we don't need warmers. Where if there's a warmer or if you have any concern, there are standard warmers and there are rapid infusers. Rather pressing it, we don't recommend, and it is really harmful applying a pressure cuff over the pack and make it pressurized. And always see how is your gauge of the cannula. If you do something, because at the end, I have seen patients, they present with hemoglobinuria. We can't find the cause. Then we have to ask several people who has connected, who has done this. Then some people say 50 cc syringe connected to a 3-way tap and they withdraw it and fast they push it. So those are the kind of explanations where the lack and the gap of the knowledge is really obvious. So and facilities also available in now main hospitals with these infusers and the warmers.
So I believe as an intern, I too have done this pushing the
it's not recommended because you can't apply the pressure equally to each area. So where the infuser, when you have the pressure devices, there's a control actually. What we pressurize is what's where the finger presses only, then some red cells will be broken because anyway it is under pressure. The red cell itself is under pressure in the pack because it has so many insults so far happened from the donor. Now it's waiting in the very artificial environment, though we think it is the best place to be there.
Okay, so thank you very much. I think it was a very comprehensive lecture, and we also learned things where wrong practices are being done. And we hope to actually, because I think there's a big amount of a lot of people trying to join in. So we will also try to share this on Facebook, on social media. So I hope that's okay by you. If anyone wants the video, please email it@slma.lk, and our team will give you a Vimeo account to get the video recording done. So thank you very much once again for joining our program. And Dr. Trilisha, thank you very much for taking the time to meticulously prepare this presentation, and you're very passionate about it, and I think it's something nice for us to see from our part. We will also inform you all about the next SLMA session, Saturday talk session, which will occur in June. Right. Thank you very much, everyone. Have a pleasant night.
Thank you very much, participants in Lanka and the SLMA. Thank you so much. It's a pleasure to share the knowledge.
Dr. Trilisha, I think there is a question from iPhone 13. Would you like to ask your question?
What is the question? Can you see, Nilanka? I
No,
can't
no,
see.
there's someone who's raising their hands up. So
Okay. Yes, please. Yes, iPhone 13. You can talk, please. Do you have a question, iPhone 13? He is muted. It is muted, Nilanka.
yes, so must be a mistake. So
Yes.
Dr. Trilisha, would you be kind enough to put your email address also on our
Yes,
chat box so that if
yes. Here
anyone
I can put. It's triliTIAW@kdu.ac.lk. Thank you very much. I'm sharing it. Some people miss the session, it seems, no? Is there a capacity you can accommodate? Nilanka?
I will talk to you about it afterwards,
Okay,
Dr.
right.
Trilisha. Okay.
Okay.
Anyway, we will
Thank
be
you very
sharing
much.
this. We will be sharing
Yes.
this on Facebook also. And
Yes. Thank you very much. Thank you so much, everybody. Thank you.